Welcome to Mitochondrial Patient Care for the Newly Diagnosed. Let's get started with a short presentation by Colleen Clark Muraresku, who will then be joined by Dr. Sumit Parikh, Dr. Austin Larson, and Lynne Wolfe.
Welcome to the special session for the newly diagnosed mitochondrial disease patients. We're very fortunate that UMDF is hosting this session again. My name is Colleen Muraresku. I'm a genetic counselor from the Children's Hospital of Philadelphia. I'm going to go through some major topics that come up as patients are newly diagnosed, and then we'll have a large section of time with our wonderful panelists. A lot of times when patients are newly diagnosed, this is extremely overwhelming. Not only are they juggling their new diagnosis, but their symptoms and then other life stressors that are occurring. A lot of times patients may feel that they're at a crossroads. So they may have been on this diagnostic journey for a long time and they received an answer, and now what? What are the next steps that they need to take in order to care for themselves? Or what does this mean? Sometimes this can be very arduous, and that's why a team and individuals and organizations like UMDF are here to help. Even with a new diagnosis, this may bring up a lot more questions, even with having a name to that. And some may still be on their diagnostic journey, but a diagnosis of mitochondrial disease is highly suspected. Thinking of an overview of mitochondrial disease, we know now that this is not entirely uncommon. The disease prevalence is estimated to be about 1 in 4,300. However, it's still very challenging for patients and providers as it can present at any symptom at any age of onset. Difficult to diagnose is still in the process with the long diagnostic odyssey, but updates with genetic and genomic testing has really been improving on this process. And then, of course, too, a lot of patients with mitochondrial disease may have been suspected, but there's also mimickers. There's a lot of disease that can also look like mitochondrial disease, and we call these listed in differentials. The first big question really is, with a diagnosis or on this diagnostic odyssey, is who should be on your team? And this is really driven by what symptoms do you or your family member have? And this is critical because medicine has subspecialized. So your neurologist is going to help to manage your seizures, but your nephrologist will be able to help your kidney disease. And it really is critical to have all those key stakeholders so that you really have up-to-date care in each of those organ systems. We even tell families when you're going to those subspecialists, sometimes they don't even know what mitochondrial disease is, but that's where having either a mito doc or a mito champion on your side that will really help to kind of educate from the mito aspects, but from the organ specific treatment that will really be with working closely with your specialist. And when you go to those specialist appointments, patients can have upwards to 16 symptoms. It's important that that specialist is aware of your medical history, but at the appointment, really focusing on what are your symptoms that you need to address with that specialist to make the most of that time. Another big question is, are you near a center that treats mitochondrial disease? And I know that can be challenging, as you know, they are located all over the US or even world, but really thinking about where are they located isn't an option for you to be able to travel to one of those centers to seek an opinion and bring that back to your local team. And also to the now with after COVID, there's a lot of virtual and telemedicine options that may now be available to you that weren't before. The other big thing is having a good primary care doctor or team. This is critical, especially in the age where a lot of people may not have a primary care doctor and they just go to urgent care or the emergency when they need support. Having someone that really knows your care, especially from pediatrics to adult, you know, keeping up to date on vaccines and all the routine care that's needed, but also being that quarterback, especially if you're not at a center that has a mito specialist or other care providers that can really help pull those puzzle pieces together with you. And of course, there's a lot of other common specialists based on the organ involvement that patients may need to see. And unfortunately, some patients need a lot of providers and some may only need a few, depending on their needs. Another big thing to think about is a lot of institutions now are having what we call complex care providers. This is more common in the pediatric group at the moment. However, hopefully in adult medicine too, there is big strides in how to care for these patients who are now aging out of pediatric care that have complex disease and how to best care for them. But these are really good individuals. Most of the times, these are pediatricians that have further trained to help with complex care needs across an institution particularly. Once you have your team situated, right, how does one pay for all the needs that come up during, a patient with complex disease? And so insurance is a big headache and help to us all when caring for these individuals. The biggest advice is understanding your insurance and plan, as well as options. If you are fortunate and you have a 2-family household, really figuring out which plan might be best for you based on employers. This may change from year to year. If you're moving states, kind of researching what does that state offer, even from a standard of secondary insurance. Even in our Philadelphia region, one area in Pennsylvania that's diagnosis driven, whether or not you can get a secondary insurance, whereas our counterpart next door in New Jersey, that is primarily income-based driven. So there is different criteria in different states, whether or not you'll be able to be eligible for a secondary insurance. This is really helpful because this can help offset costs of insurance plans. And also being cautious when you're picking insurance plans, if it's participating in the main hospital that you already seek your care in, or if it isn't, kind of what would that price point look for you all. Also, Medicaids versus Medicare, kind of determining if you're eligible for any of those types of insurance, which can also offset commercial and other insurance plans. Also, patients are informed, right, a lot about your insurance and what things will be covered. So there's items called predetermination or explanation of benefits. These aren't charges, they really are explanations of what could be your patient responsibility. However, it's important to kind of follow up with the insurance and or your care team to really understand that. UMDF had a great talk on healthcare and billing during COVID, so hopefully you'll be able to go back and reference that. But really, it's important that, unfortunately, a lot of times your physician and team might not have insight into your hospital billing. So really contacting those individuals on the bill to see if anything can be worked with. There's usually payment plans and options available to individuals that need it. Another big support person is case managers. So a lot of insurance plans have case managers for patients with complex needs. So that's one point person who can help understand your plan, and they can aid in authorizations, referrals, updates, and that you can pass that along to the insurance individual that works in your physician's hospital or office. Other types of insurance is disability insurance. So really determining, from a Social Security standpoint, we traditionally think this is for individuals 65 and older, but also individuals who have visual deficits and other disabilities would be sometimes optional, have the ability to apply for this. Types of disability plans, a lot of families who may be going through a chronic medical issue or need to be out of work, there's short-term and long-term plans, really understanding what might be offered to you. Typically, individuals who have social workers part of their programs, this would be great to be able to touch base with them to really see what might fit the needs for what you're looking for or might be eligible for. Other types of disability, which a lot of people might not think about, but we think of learning, communicating, mental health, social relationships, all of that helps to define the scope of disability an individual is experiencing. And there's a lot of other resources. So thinking about what is needed, and depending on your child or your own individual needs, there is the Family Medical Leave Act, which doesn't pay you to be out of work, but it does give you protected time up to 12 weeks. There's also services such as early intervention, which will be able to provide therapies needed for younger children or individuals. And then there's other legal services, which, thinking about as children age, what would be the best way to help ensure that they're going to receive proper medical care? Perhaps they have intellectual disability and wouldn't be able to provide their own medical decision making, where those individuals that might be more beneficial to apply for guardianship, where someone else, typically the parent or caregiver, would take over that responsibility. However, sometimes individuals are very cognizant and able to make decisions, but at times where they may have a stroke or chronic issue and be in the hospital, it's important to have other areas that an individual can help and make those medical decisions where a power of attorney may be helpful. Also on the watch page, you'll be able to find a lot of these additional resources I'm going through under the event resources. Another big thing with financial assistance, I think we all think finance is always based on income, but that's not the case. We've learned a lot from our families, and I'm sure you all share with each other, to communicate and share what resources that individuals have found or ways to help with support. There's a lot of different resources to help kind of cover medical expenses, such as nursing support coverage, medical grants, equipment, supplies, and then even living expenses. People typically think of this may just be household related items, but really those medical bills and medical needs are included in the living expenses. So occasionally there might be grants for one-time bills, or if there was a change in income. I think people sometimes hesitate to ask for financial aid, but this is really important. We all want you to be able to spend your money wisely on the care that's needed, but if there are opportunities to help us and help you all cover that expense, that's important to know. Especially travel grants, post our COVID world, individuals are starting to travel again for their medical care. And, before making an appointment or even deciding if you can go to that Mito center, talking with the individuals to really see, is there other arrangements that can help offset the cost? Obviously, people have to take off work and either fly or drive and then stay in hotels to receive care elsewhere. And there's a lot of great flight options. Some are location-based and others are based on other medical needs, but a lot of different resources are available. And fortunately, we've still seen a lot of these grants ongoing post-COVID, which is great. The other important thing is medical supplies. Looking at other resources that may help offset the cost. So a lot of big one that a lot of families use is the Mito Action, which is disease specific. It's a one-time $500 grant that could be used for, whatever the family wishes, whether they use it for their care or medicine or equipment needs. And then there's a lot of opportunities for equipment needs, especially with wheelchairs sometimes not being fully covered, or when an individual needs an upgrade to the wheelchair, or even all the accessories that are required. So the adaptations in the house, as well as the van and the wheelchair ramps that are needed for individuals. There are many resources now that are offering some abilities to offset that cost. Another one, which isn't Mito specific, but really great at looking at different options and prices for medications, is Good Prescription or Good RX, where you can also find coupons to see and compare pricing. And, with Mito disease, right, this is not just about typically the patient that we're caring for, but it may also mean, what does this mean for the family? And in a lot of mitochondrial disease, such as the maternally inherited, we may see one individual and then be diagnosing several individuals in the family, some more severely affected than others that need care for. In recessive conditions, This may have implications for siblings or future pregnancies that would be able to support that family and their family planning. And then other conditions may be de novo or brand new in that individual, or there may not be as many individuals affected based on symptoms and the genetic etiology. But once you get a diagnosis of mitochondrial disease and you go through your specialist and get a care plan, right now we don't have a cure for mitochondrial disease. It is symptom-based management, but this is a goal of UMDF and all of these providers to really find a treatment and cure for these conditions. And what does that require? Clinical trials and research. And this is important. There is many clinical trials coming down for the pipeline, excitingly for both pediatrics and adults, and really finding what's going to be the best fit for you and for your family. I always encourage individuals to still seek information about the trial before saying yes or no. The coordinators typically would be able to provide you with additional information, kind of what would this mean from a time perspective, side effects, if any are known, and really kind of if you meet eligibility criteria. Also, too, the exciting thing is there is many trials coming down the pipeline. So if you're not eligible, I always say don't get discouraged, because the eligibility criteria is there for a reason, whether from a safety perspective, right, that drug would be unsafe to try in a patient of you, or the other thing is for other reasons, such as we need the right group that this drug would make the most benefit in, because if we take through a big catch-all, we won't be able to get the best outcomes, and therefore we could slow down the progress of that drug coming to approval. And research, research is wonderful, and in rare disease, a lot of our patients are asked to participate in a lot of research, and you all can participate in as much or as little research as you would like. We always say the more eyes on the patients, the better, and most of our patients are more than willing to share their research and information to really push forward. And this is how we've gotten the progress we have in the past several years and where we're at now. The biggest thing is, obviously you're not alone, right? This is a community. You need a village to care for patients with mitochondrial disease. And that's why having all of these providers get together and have this wonderful meeting, as well as having organizations like UMDF to really help to bridge the patient and the research and the clinical expertise to help push this field forward. And I will end there, and we'll take questions for Q&A with the panelists.
Welcome, everyone, to the newly diagnosed panel today. I have the privilege of introducing our panelists today: Dr. Sumit Parikh from the Cleveland Clinic, Dr. Austin Larson at the Children's Hospital of Colorado, and Lynne Wolfe, here, nurse practitioner from the NIH Undiagnosed Disease Center. You can feel free to ask some questions in the chat, which we'll receive directly through our moderators for the session. So we'll kick off with some questions for the panel. So first one we'll give to Dr. Larson. If you just received your genetic test results back and you have a mitochondrial disease, should you start supplements right away or wait to see a specialist?
Well, I think it depends on what the diagnosis is. So particular mitochondrial diagnoses might have an indication, a very strong indication for a high dose of one particular vitamin. So for example, coenzyme Q10 synthesis deficiency, in that scenario, a very high dose of coenzyme Q10 would be indicated to treat that disorder. Likewise, there are thiamine responsive mutations in pyruvate dehydrogenase deficiency. And there are some other examples where there's very clear mechanisms that would link a specific genetic diagnosis to treatment with one particular supplement. In terms of the question of whether in general, people should start supplements immediately. I don't know. I would say that it's probably worth a discussion with your physician. I would hope that the person who ordered the genetic testing and is interpreting it for you can kind of help you to figure out if you're in that scenario where your specific mutation has a very strong mechanistic indication for one particular disease modifying therapy versus a more general approach to mitochondrial supplements. So that would be the thought process that I would be going through in that scenario.
Yeah, if I could make a comment, Sumit Parikh here. So I think one of the things I do tell my families is that while we're trying to standardize the approach to much of the care our mitochondrial patients receive, the one place where there is a lot of variability is supplements. And a lot of that has to do with just we don't have the science to necessarily back up completely what we're doing. And so like Dr. Larson said, there are absolutely some mitochondrial diseases where a specific supplement is going to be strongly recommended, and it'll be recommended by all the docs that you see. But for the vast majority of mitochondrial diseases, what we call the mitochondrial cocktail or a combination of supplements that get used, unfortunately still vary depending on the provider you're seeing, just because each group or provider has their own favorites. Some of this is based in science, but some of it is based on experience. And you will get a lot of variability. So if you go and get maybe more than one opinion as to what needs to be started, I warn families that this is one place where you're going to see variability, and that's okay because there is not one right answer necessarily. In the same vein, there may also not be a dramatic improvement or effect from some of these vitamins or supplements either, and where we're using them in the background to hopefully help shore up mitochondrial function. And it also depends on what part of the world you're in the United Kingdom, in some parts of Europe, they will not prescribe supplements because they feel the science is not there to back up supplement use in general for most mitochondrial diseases. Most individuals in the United States prescribe at least a few things, but we really try to balance how much our patients need to take. And we want to make sure it's not at the cost of nutrition or medications they really need. Dr. Cohen tells a story of where a family came in once and had a grocery bag and pulled out 20 or 30 supplements. And we very much try to avoid doing that.
And I'll just add one more thing. For certain disorders now, as you guys have heard for several years now, there are clinical trials for drugs and other treatments. And depending on the diagnosis that you have, the provider that you're working with should make sure that you're not eligible or your child's not eligible for participation in a treatment protocol that actually may be of more benefit than some of the supplements.
Fun discussion. We do have a question from the chat for anyone on the panel. What steps should a patient take if they've been told they have a possible diagnosis of mitochondrial disease?
I can start with that. I think that's an extremely frustrating place to be. I think whenever we or our family members have symptoms, we really want an answer in the hopes that we can kind of get a playbook then to make sure that we can help them. And ending up in the unclear bucket, it might be, it might not be, or it's not, but we don't know what it is, I think is a very challenging place to be. We usually tell families in those situations to make sure that you don't close any door. One, if there might be a concern with how the mitochondria are working, protect them. There are some precautions you can take as far as care goes, as far as monitoring and what we call active surveillance goes, to make sure that nothing catches us by surprise as far as heart or kidney or liver function. And those things can be monitored relatively easily. We also can try supplements in case they do help a person feel better. But at the same time, we also want to make sure your medical team stays open-minded that they don't close the door on looking for problems. They don't chalk everything up to a mitochondrial issue, because it may not be. Even for our mitochondrial patients, it may not be. And we would hate to miss something that we could treat or treat differently. And we want to keep that diagnosis door open, because we know that as our knowledge and technology has improved, lots and lots of patients that were diagnosed with a possible mitochondrial disease using older technologies like muscle biopsies or skin biopsies, we have now been able to relabel with an accurate diagnosis where we know that the mitochondria may get affected secondarily, but that's not the brunt of the problem. And having that correct diagnosis, even if it's 3 or 5 or 10 years later, would open new avenues of support. It would open new clinical trials that you may never have known about. It would also change the prognosis, and it can also change what we're doing as far as management goes. Now that we know that it might be this other condition, if it doesn't affect liver or heart, we don't have to burden you or your family member with checking all of that all the time. But we do ask kind of that both of those paths get walked simultaneously.
Yeah, so I'll be a little bit more, I'll pick up where Dr. Parikh left off and be a little bit more specific. So, what Dr. Parikh is saying is that our diagnostic tools have changed dramatically over the last, say, 5 or 10 years. And if the question is, is there a potential disease-modifying therapy for the symptoms that someone has, the best way to identify that in almost all cases is with broad genetic testing. And so to Dr. Parikh's point, we've had patients that have been followed for years with possible mitochondrial disease, and through genetic testing, they've been identified to have a different disease process entirely. And in some cases, there is a disease modifying, or at least a mechanism directed therapy based on that alternative genetic diagnosis. The other thing to note is that, as Lynne Wolfe mentioned, there are more and more clinical trials that are available, but the inclusion criteria for those clinical trials is almost always genetically diagnosed mitochondrial disease. So, it really depends on what you mean by possible mitochondrial disease, but the most powerful diagnostic tool that we have right now is broad genetic testing to go from that scenario of someone is considering mitochondrial disease to, is there a specific diagnosis with a mechanism that we understand and can intervene on that mechanism?
And I guess I'm just going to add that both what Dr. Parikh and Dr. Larson have said about keeping your doors open and aggressively pursuing a definitive diagnosis, whether that ends up being a real mitochondrial diagnosis or secondary mitochondrial dysfunction related to a different diagnosis, ultimately really impacts therapy, prognosis, other family members that may or may not need to be treated. So there are research, diagnosis-based research available for patients that are still undiagnosed and looking for a definitive diagnosis. And this particular group of patients with the possible mitochondrial disease, actually we see quite often in the Undiagnosed Diseases program at NIH. And we frequently find, but not always, a non-mitochondrial diagnosis for those patients. And sometimes we find either a new or very atypical presentation of a known mitochondrial disease, but what you can do in research to really dig in sometimes is a little bit more than what any of us can do in academic medicine because of insurance limitations and travel limitations, et cetera. So if you are unclear on your diagnosis, I would encourage you to turn over all the stones so that you can get one to be sure you're getting the right treatment.
Excellent. And to piggyback a little bit on that question and research, whether genetically confirmed or possible mito, If someone is enrolled into research with their local team and they see another study they would like to participate, should they share that with their local team? And is it safe to be in more than one research study?
Yeah, I mean, we co-enroll patients all the time. I don't know if Dr. Parikh or Dr. Larson have any thoughts on that, but we absolutely co-enroll patients. So, you know, we may have a patient, for example, in the undiagnosed diseases program, and then we diagnose them with a mitochondrial disease program, and we'll refer them back to a mitochondrial disease center or a pharmaceutically based treatment protocol or some other type of research. And so it's not unusual for some patients, not everybody, but for some patients to be enrolled in more than one study. The limitation usually is you can't be in multiple drug studies, right? That would cancel each other out, and you would never tease apart what's actually working or not. So there are some caveats to co-enrolling in multiple studies, but certainly diagnostic or natural history protocols and treatment protocols do co-enroll.
Yeah, and I would just add, it's always very helpful to share all the information you have with all the people that you're working with. So, we don't, sometimes it can be helpful for multiple people to be working on the same thing at the same time. But often if we understand, for example, what's going on at the undiagnosed disease program at our clinic, we could take an alternative approach and we can make sure that we're doing something different, something that's complementary, but not redundant with what's going on there.
Yeah, and I'll echo that we all want to make sure that there's open communication. We want to serve as your guides. We want families to not feel fearful or that they're going to hurt somebody's feelings by bringing up, well, there's this other study at this other hospital. If I bring it up, my doctor's not going to see me or my team's not going to take care of me. If you have that person who does that, they probably don't belong on your team anyways. We all kind of need to work together on this. We also want to guide you and make sure that it's the right type of study for your child, that it's the right provider, that the research that's being done is on the up and up. And for all those reasons, we want those open discussions. We still, even if you want a second opinion, we want to hear from you. Even if a diagnosis is known and you've got a care plan outlined and you still want a second opinion, there's nothing wrong with that. So I think those are discussions we really would want you to advocate for and not feel embarrassed or afraid of breaking up with your team.
Yeah, and Dr. Parikh brings up a great point, which is that you want multiple people with different perspectives to give you opinions, and particularly as we have more and more interventional clinical trials available, can be difficult to assess the risk-benefit ratio of a clinical trial. So, early stage trials are different from late stage trials. Preclinical information can be interpreted in different ways by different people. So, it is worth getting multiple opinions, particularly in that scenario of, potentially participating in an interventional clinical trial.
Excellent. And some of the chat questions: how does one who's an international patient obtain a consult with a U.S. specialist? If any of those on the call take international patients?
So the simple answer is there's probably not one right answer, and it's going to be complex. Some of our hospital systems allow for international consults. Our program has something called My Consult or eCleveland Clinic that allows for those types of consultations to happen, where you provide all the information and then we review everything and then provide you with some guidance and a care plan. Other hospital systems likely have things like that. We, as part of the National Mitochondrial Care Network, are very much trying to launch a telehealth program, but have put things a little bit on pause until we see where the rules and laws around telehealth end up after the pandemic. But it is something that we would love to offer.
And I think for some patients around the world, if you want to come to the United States for face-to-face consults, that gets even a little bit more difficult because very often there's a high out-of-pocket cost, both for travel and for some of the testing that might happen in America. But we are in a day and age where we have lots of colleagues all around the world. We are not a huge group, and we are used to collaborating. And so you can ask the question if you find out that there's a physician in America that is doing something that you think would benefit your child or you or some other family member, reach out and ask the question, get some more information, and see what the resources are.
And I'll just add a little bit of what Lynn said too. At CHOP, we have a whole international medicine program that works with families to provide that cost estimate and kind of working with families, which it can be a high out of pocket, and some things may be recommended for you to obtain locally and bring those records with you. I think the other benefit to COVID is we're all learning to do this more virtually, including clinical trials and natural history studies. So I think that's exciting to work more internationally, hopefully, when post-COVID world, when we settle. Anything else to add to that question? All right, a little bit of a trickier question. How should one go about being diagnosed with a secondary mitochondrial disorder, and should they all have genetic testing?
I'll start. I have to just echo what Dr. Larson said. I think we are in a day and age where molecular testing gives us the biggest bang for the buck. The limitation being that some insurance companies still consider exome or genome testing to be experimental or not fruitful, and would rather that you pursue a panel first. And I think that the way to do that is make sure you're plugged in with a geneticist or a neurologist that is really used to doing genetic testing and has a genetic counselor available to help interpret the findings of any genetic testing. And even if you have to start with a panel or a single gene test, if there's clinical suspicion regarding something specific, then move up to something more general to try and identify a molecular cause. You certainly should do that. That aside, if there are insurance or financial limitations, there are a number of genetically based research studies all around the country. Seattle has an investigational program. Duke has an investigational program. Columbia in New York has the Discovery program. There's any number of places where you can access getting exome or genome sequencing done that doesn't actually bill an insurance company or cost you a lot out of pocket. And so that's a discussion to have with your provider if they can't get the testing done for you that they think is really needed to give you a diagnosis with the resources they have in their clinic or at their hospital. Ask them, what other resources might you tap?
Yeah, I would just say that it's important to understand the primary mechanism. So there are a lot of things that can result in secondary mitochondrial dysfunction, but if there's going to be a disease-modifying intervention, it usually has to target the primary mechanism of the disease and not a secondary mechanism. So we've talked around this a little bit, but there are a couple of different scenarios. There's sometimes a scenario in which the biochemistry or the imaging findings or the clinical scenario are extremely specific and highly suggestive of mitochondrial disease, and yet the genetic testing is still not diagnostic. In that case, it may be very high yield to participate in one of these research programs. In other scenarios, the biochemical findings, the mitochondrial enzymology, the imaging are more non-specific. And so the likelihood of identifying a single gene that is causing that clinical presentation is lower. And that's something that we can guide you through based on our experience of like, what are the next steps if the genetic testing is negative in this highly specific clinical scenario versus a more non-specific clinical scenario.
And remember, our genetic tools, while they've improved, they're still quite imperfect. I mean, we're fortunate enough, depending on who we're looking at, to hopefully find an answer 40 to 50% of the time. If we have a very narrow pool of highly selected patients where we're suspicious of something, that number might be higher. But if we just take all comers, the number may be as low as 25 to 30%. So these tools are improving. And because the answer that we find sometimes really shakes things up as far as what the condition is and the diagnosis is, we just ask you to kind of keep that open mind in place. It's one of the reasons why we've made a big push for, in the mitochondrial medicine group, to not use the term possible mitochondrial disease, because for many people on your team, they close their minds to another diagnosis. They just think that that's the diagnosis. They run with it. It creates a lot of anxiety in families because people just worry about something progressive, something degenerative, something that's going to take over their life and every organ in their body. And then the care that gets provided is not as personalized or as mindful. So for all these reasons, we've even asked clinicians to try and change the terms that they use so that if there is mitochondrial dysfunction, we say, okay, there's mitochondrial dysfunction, we haven't figured out why. And leave it at that we don't know what exactly is going on. But there is mitochondrial dysfunction. And like Dr. Larson said, there may be some situations where really the condition really aligns in such a strong way that mitochondrial disease might be in that top 2. And we just need to wait for better or smarter genetic tools or research tools to get to that answer. But for many other conditions, it may be in the top 10. And we need to make sure we keep looking for those other 9 things.
And remember, at the end of the day, mitochondrial diseases still are quite rare, even though as a group they look like there's a lot of them. They are quite rare, and secondary mitochondrial dysfunction is well recognized in, inflammatory disorders like rheumatoid arthritis and Sjogren's disease and psoriatic arthritis and cancer syndromes and toxic ingestions. The list goes on for all the different more common diseases or environmental things, medications that can impact on mitochondrial function. So I think the most important thing is to have serious discussions about next steps with your clinical team if there's a suspicion of a more non-specific kind of mitochondrial dysfunction going on, so that you're sure that you maybe have to include different specialists in your team, that you don't necessarily, as Dr. Larson alluded to, put too much emphasis on genetic testing when some other testing may actually be more illustrative. So this is a topic that really is complex and requires a lot of discussion.
And I do want to let everyone know, so if you go to the Mitochondrial Medicine Society website, in the educational links, there was a paper written for physicians that lists, at least when it was written, many of the known causes of secondary mitochondrial dysfunction. And the authors that helped us with this, many of them on this call, help put those tables together where we've seen muscle biopsy abnormalities, we've seen skin biopsy abnormalities, we've seen lactic acidosis, we've seen MRIs that look like Lee syndrome, and all of these other conditions were found as our genetics improved. But in case anybody's interested, that paper is available for free on the Mitochondrial Medicine Society website.
Excellent. To kind of stick with the diagnostic topic a little bit longer, is there an age limit in which someone should stop pursuing a diagnosis?
No. The Undiagnosed Diseases program just admitted an 80-year-old the other day. So, I mean, I think if you're having problems, and especially if they're new to you and they're impacting your quality of life, and you're motivated, go for it. There's no reason why you can't.
Yeah, I'll echo that. I mean, the oldest patients in our mitochondrial clinic are in their 80s with genetically confirmed mitochondrial disease, and there are folks with onset of symptoms in their 70s. I will say, as just a rough approximation, in those more non-specific scenarios, the likelihood of finding a monogenic or a single gene that is causing something generally goes down with age. But when we see very specific symptoms, even in someone who is 60, 70, 80 years old, we absolutely do diagnose primary genetic mitochondrial disease.
Fun. And keeping, like I said, with the diagnostic topic, we also have, is organic acid a good test for either primary or secondary diagnosis?
Go for it, Sumit.
So that's a very good question. There's not a simple answer. A lot of our biochemical tests in the right hands have a lot of power, but there are a lot of things they can also uncover in secondary mitochondrial dysfunction. So again, I'll make a pitch for a Mitochondrial Medicine Society paper that goes over the diagnosis of mitochondrial disease, again, written for doctors, but it does a deep dive into the strengths and weaknesses of each of the tests we use, from amino acids, organic acids, carnitines, muscle biopsies, skin biopsies. And it goes through the strengths and the weaknesses of those tests, the yield and utility of those tests. And that is available for your clinicians should they need that information. We see abnormalities in the blood and urine testing, in the skin and muscle biopsies, in patients with primary and secondary mitochondrial disease. And we need that experienced clinician who's able to help you sort this out. I wish it were straightforward, and sometimes it is. For some families, there's a lot of diabetes and hearing loss, and a child presents with stroke. You, as a parent or family member, may be able to Google that and figure out that that's going to be knee loss, and it's done. And we just have to help confirm it. But there are other times where that's not as straightforward. But
go ahead. I was just going to say very quickly that, no single biochemical test in and of itself is going to be useful. So when most of us look for mitochondrial disease, if we're using biochemical tests, there's a number of them that you have to use to cover all the pieces of the pie. And you have to recognize that different disorders will have abnormalities in different body fluids, and age may give you different results. When you're very young, there may be a lot more lactic acidosis than as you develop older patients with mitochondrial disease. So there's not one gold test. You have to have a really good clinician, and you have to look at lots of different information.
Yeah, and to pick up where Lynn left off there, this will get slightly technical, but I think it's worth it. So, anytime you do a test, you have to, it's not completely arbitrary, but you have to define a normal range. And the normal range is going to be, that's going to encompass the majority of results, but there are always going to be outliers on either side, high or low. And the more tests that you do, the more out of range results there will be. So organic acids often, they will comment on the concentration of 20 or 30 or 40 different metabolites. And when you look at the concentrations of that many metabolites, you can be almost certain that at least a few of them are going to be out of range. So to Lynne's point, what we're looking for is a pattern of abnormalities that are all pointing to the same underlying mechanism across multiple different independent tests. And that's really what we're looking for from a biochemical perspective. So, a single metabolite that is out of range, that's expected. If you're looking at 20, 30, 40, 50 different metabolites, you're definitely going to have some abnormalities.
And, one of the more dramatic teaching examples that I use with residents and doctors in training is you can have things line up and look completely like a mitochondrial disease. I had a woman who was in her 40s who had everything. She had lactic acidosis. She had those amino and organic acids showing abnormalities. She had a muscle biopsy that showed ragged red fibers. She had MRI lesions that were concerning. She had muscle and nerve disease. In anybody's hands who has experience, they would have said, boy, you really look like you have a genetic mitochondrial disease. Dr. Cohen had taught me, he's one of my teachers, to always check for poisons and toxins that don't belong. And so when we did that screening, she was found to have very high levels of arsenic. And it turned out, long story short, she was being poisoned. She was being poisoned by her husband. I've never had a case like that again. But I will always remember it because, the joke or the punchline is that she didn't need a mitochondrial cocktail. She needed a divorce. And that was her treatment. And while I, kind of jest a little bit, it's very serious in this case that she really got the right diagnosis, because when we saw her 2 years later, she was completely better and healthy again after she came off all of that arsenic. So.
Excellent stories too. One other good question for the group is, what is helpful for a first visit to a mito specialist, aside from just obtaining the records? What can parents do to make the most of that visit and, to be the most beneficial?
Well, I'll start, and I'm sure that Dr. Larson and Dr. Parikh will weigh in. I think that what is really helpful is if parents are able to organize medical records, imaging CDs, videos of seizure activity, all of that information. If we get it enough ahead of time, we can review it and have a really good idea about what we want to pursue when we see a new patient in clinic. But just as important is the parents thinking really hard and maybe making a list of, what are their major concerns? What are their questions about, other diagnostic testing that needs to get done? Is this definitive, or does something else need to confirm it? What kind of treatments might, be available? If there's additional siblings, is there family testing that needs to be done? If there's other, more extended family members. And so parents that come with a lot of questions and they've really thought through things and they've been able to get us the records ahead of time, I think those become the most fruitful appointments. If a parent shows up with a child and they don't really, they haven't really given it a lot of thought, we have to drive the discussion. That gets a little bit harder to address specific family concerns and priorities. And I think we all sort of strive to support our families and patients. So it's nice to hear directly what are the major concerns.
And I think Lynne covered that really nicely. I'll just add one particular point is that it's very helpful to have the genetic testing results from the primary source. from the lab that did the testing. So the genetic testing is kind of susceptible to transcription errors, and those mistakes can kind of get propagated through records. So having primary sources is huge for me. Okay, sorry.
And I think the only other thing I would add is that the Mitochondrial Care Network did come up with a guide for families that have been newly diagnosed. You can just Google mitochondrial disease newly diagnosed guide. I believe it's the first link on Google that comes up. Or you can just go to the Mitochondrial Care Network website and Google for that, and then you'll find the guide right on there. And it walks through some of this as well as a lot more. Again, some of the people on this call were very helpful in helping develop this guide.
Excellent. I know we're close to time, but maybe we have time for one more question. That came up is hyperbaric oxygen therapy recommended for mitochondrial disease?
Sumit, go on. I know you have an answer.
I was going to say, any takers?
So I think I would be very cautious with any alternative therapy. There are, hyperbaric oxygen is being touted for a lot of things, from autism to overall brain health to some people have even said for mitochondrial disease. Just to let you know, there's actually Dr. Mutha, who's at the Broad Institute, is actually finding that for some mitochondrial diseases, not giving oxygen may potentially be beneficial, or lowering the oxygen that the person gets. So I think we have to be very cautious before we put any of our patients through anything that is not a proven therapy. And I would say clearly hyperbaric oxygen is an unproven therapy at this point in time, just like stem cell delivery is an unproven therapy at this point in time for mitochondrial disease. On the flip side, we have seen, unfortunately, children who have received hyperbaric oxygen and have had new lesions show up in Lee syndrome. And so I would warn anybody against, kind of trying these things unless it's part of a supervised research study at a major hospital or institution. Please just be cautious, because the last thing we want to do is make anything worse for our patients. We're already struggling with so much.
Yeah, I'll just echo that. I give the same advice that Dr. Parikh does. I would advise against hyperbaric oxygen given the data that we currently have.
Right. The last question we have in the chat is, have any of you reviewed the heart rate variability in mitochondrial function assessments by Dr. Michael Kuceris? Anyone familiar with that?
So not him specifically, but I think that all of us probably have lots of experience with the dysautonomic dysfunction in our mitochondrial disease patients, and heart rate and blood pressure fluctuations are actually quite common in a number of mitochondrial disorders. And there are different ways to both diagnose and monitor those types of fluctuations. I am unaware of any particular research or more specific therapy for those, but Dr. Larson or Dr. Parikh might be.
No, I'll just say as a more general point, heart rate variability is one biomarker that we can follow, and we're going to have a whole bunch of biomarkers and metrics that we can track going forward. And I'm really excited to see what comes. The technical term might be deep phenotyping. I'm really excited to see what comes of that, and what kind of correlations we can turn up from those sorts of wearables and the deep phenotyping that will be possible.
Another question a lot of us all receive a lot: what medicine should I avoid if I'm diagnosed with mitochondrial disease?
Here, yeah, I can take that. And hopefully the answer will be short. That list used to be very long. There is a recent review on the Mitochondrial Medicine Society website. And the simple answer is, outside of valproic acid, almost all other medicines are fair game, but you can definitely make sure that your clinician reviews it and make sure it's safe for your specific mitochondrial disease. But some maybe need to use with caution because they may make lactic acidosis worse, but it doesn't mean they can't be used. There are select antibiotics that have to be avoided in very specific mitochondrial diseases, but it is not a laundry list of 5 or 10 or 20 things that need to automatically be on the do not use list, like it used to be.
Yeah, and I echo what Dr. Parikh said. We are really simplifying what we're considering to be mitochondrial toxins. Metformin is a mitochondrial toxin, even in an individual without mitochondrial disease. But those medications already come with warnings on them that say this medication might cause lactic acidosis. I've had a few of my patients with Kern-Sayers or with me loss and diabetes that have had really pretty significant lactic acidosis on that particular medicine, only because it makes their existing condition worse. But it's so few and far between, and it's so specific now to certain disorders that I think most everybody should really not be overly concerned about that.
Excellent.
All right.
Are we wrapping or going a little bit longer?
Yeah.
Welcome back, everyone. I am Brian Harmon, President and CEO of the United Mitochondrial Disease Foundation. On behalf of UMDF, thank you again for joining us. We hope you have enjoyed today's programming and that we have done our part to lighten your mitochondrial disease journey, even if just for a little bit. If you have missed any of the main stage sessions or would like to go back and rewatch, they will be housed on this website throughout the summer. You can also check out MitoU on umdf.org, where this content and other great educational content is available. As much as we hope that you have learned from us today, know that we are learning from each and every single one of you. Please connect with us on umdf.org or reach out to our staff. You have a team at the ready to support and guide you. And last but not least, please allow me to extend my appreciation to our meeting event planner, Kara Stripmatter. She eats, sleeps, if she gets a chance to sleep, and breathes this work. I'm grateful for her leadership on this event. We salute our dedicated staff and their army of volunteers who have made this event possible. In our unrelenting pursuit for a world without mitochondrial disease, we can't do it without them, and we can't do it without you. Thank you once again.
We are so excited to announce that we will be back in person next year. So save the date for Mitochondrial Medicine 2022, and we can't wait to see you in Phoenix next June.
Hi everyone, this is Brene Wilkerson. I loved being your junior host this year. Thank you for taking the time to be with us today. I learned a lot and I sure hope you did too. I can't wait to see you all next year in Phoenix. Stay healthy, stay safe, stay energized. Bye!